Formally, Sourangshu is a faculty member in computer science and engineering at IIT Kharagpur. He is also a visiting scholar at the Helsinki University of Technology and has earlier been a scientist at Yahoo Labs, Bangalore. Sourangshu holds a PhD in computer science from IISc Bangalore and a master's and a bachelor's degree from ISI Kolkata and IIT Roorkee. He says on his website that he's broadly interested in machine learning. Let's listen out to him how he has applied machine learning and AI in the context of artificial intelligence and medicine with the talk today. Over to you, Sourangshu.
Okay, thank you very much for the introduction, Chirantan. So, and thank you very much for inviting me to this, for this talk and, to this wonderful audience. And hopefully it will be an interesting discussion. So, so in this discussion, I'm going to describe a work which is okay. I should have said intelligent screening of of patients with esophageal cancer. Okay, so so this is okay. Yeah. Okay, so this is work of my PhD student Ashish Ray. He's the main guy behind the work, and he passed away in 2019, and now he's a data scientist in TCS. Along with so I was his supervisor, and along with me Professor Kalyan Guin, who unfortunately is not there with us anymore. He was supervisor to Ashish Ray as well, and this is so this is a joint work between us. Okay, so this is a very generic agenda. So let us go ahead with the introduction part. Is it visible, the entire slide? Because
yes, it is visible. Keep going.
Yes. Okay, great. So okay, so yeah, so basically our motivation for this work, it comes from various things, but I just want to motivate with a bit of data. Okay, so there was a survey. I mean, this data is from UK, and I think it's NHS survey. Okay, and with about, I mean, greater than 1,300 participants, and so the survey was about trying to figure out why people avoid medical care in the UK. Okay, so 33% of the participants reported unfavorable evaluations of seeking medical care. That is to say that they don't think the doctors will help them. Okay, okay, so that's one part. 12% reported low perceived needs. So they don't think that they need to seek medical care. So they are not sick enough to seek medical care. But a whopping, I mean, 58.4% of the participants reported barriers to medical care. Okay, out of which most of the people reported high cost. Okay, many of them said no health insurance, and many of them said time constraints, so they don't have the time to go to the doctor or something like that. Okay, and and then we can see that so this is a little bit old data, but for somebody who is suspected of cancer in the UK, you need about 2 weeks to get basically the waiting time for I guess a visit to the hospital or something like that is 2 weeks from the day of the communication. Okay, and this can go up to very high for other illnesses like mental illness. Okay, and yeah, There are a certain number of people who actually pass away while waiting for an initial consultation. Okay, and this is really sad. And the sad part is that this has actually risen from 2013 to 2017. So we don't know about what happened afterwards, but this is one thing. So in India, the situation is much worse. Again, this is a bit of old data, but we have, one government allopathic doctor for every more than 10,000 people. Okay. One government hospital bed for every 2,000 people, one state-run hospital for every 90,000 people, and so on and so forth. Okay, and you can see the numbers are really bad. So about like 1 million doctors, okay, to treat about 1.3 billion people. Okay, so so things are really bad. Okay, and so this kind of stages the motivation for our work. Okay, and what is the so there are basically I would say two main things. So what we want to do is we want to help the situation through AI. So that was our motivation. Okay, and two things help our cause. The first is that electronic medical records have become ubiquitous now. I mean, and of course, diagnostic tests are costly, painful, and time consuming. Okay, so in this, under these two conditions, can we optimize and customize the diagnostics tests, okay, that have to be performed as per the individual's needs without compromising on the detection of the suspected patient? Okay, so this is our objective. So this is what we want to do. Okay. So basically, so the way we achieve this is by using, of course, some sort of an information technology related solution. Okay, so what we want to do is we want to recommend tests so currently what happens is that the moment the patient sees that he or she is sick, they have to go to a doctor or a medical institution, and then basically the doctor or the medical institution accesses a kind of a clinical decision support system, which recommends something like so sometimes the decision support system may recommend some kind of test or something. I mean, in many cases the doctor would just use his or her knowledge to recommend the tests or the course of action. Okay, our idea is that can the patient first get the recommendation for the tests, okay, and then go visit the doctor. So that is the key idea. Okay. Okay, so these are the research questions that we ask in this particular work. So broadly, two categories. First is, can we augment the healthcare process by predicting a suspect without intervention of a doctor? Okay, so this is the first thing. Okay, okay, and obviously, one cannot perform a lot of tests. So the objective here is to sort of predict the suspect with a few basic tests, okay, which is, let's say, less than the prevalent recommendation, okay. And then can the risks associated, so that was the first thing. And second is, can the risk associated with this process be mitigated? So what do we mean by risk here? So basically, we don't want any false normals, okay. We don't want a patient to be classified as a non-patient simply because we didn't have enough test data, okay. So this is the risk associated with the procedure. And the second part of our study was that, can we make it effective for the patient? So from the patient's point of view, so maybe we have taken sort of two dimensions to this effectiveness. One is, can it be cost effective? So for example, if the patient provides a certain cost budget, can we accommodate the tests within that cost budget? And can it also cater to the comfort of the patient? Okay. So these are the research objectives. Okay, so are the research questions that we want to answer. And so we basically sort of divide our work into three objectives, you can say. So the first is that we want to see if we can learn a good classifier, okay. And second is, can our classifier basically find the suspected patients with high accuracy and high sensitivity, and sensitivity being 100% here. So our aim is to achieve high sensitivity. Okay, and then the third objective is selecting medical tests optimally as per choice of patients, doctors, or other stakeholders. Okay, so we are just talking about the methodology here. The application can be anything. Okay, okay. So a bit about the data set.
Do you want to take any questions now, or you come back later?
Oh yeah, I can. Sorry, I can take the questions. So I would like to take the questions online. Yeah.
Okay, so folks, if you have queries, just put it on the chat window. I do have a quick, not a question, but a comment, which is, do you have a sense globally how classifiers are being used to reduce the burden of both costs and preventable outcomes on the patient side in medicine? Like, are they in practice, like especially they're doing well in cancer, perhaps not doing too well in ophthalmology? Do you have a sense of that?
No, I don't actually. Yeah, so that's a good point. So what we did, so this particular work was, I would say, so I must give a bit of a disclaimer here. So I'm not really a medicines person. I'm more of a methodology person. So I'll focus more on the methodology part. This particular study was done on esophageal cancer. So at the time, so I'll come to it. Maybe I'll come to that portion of it in a moment. Okay, but you are right. So so actually, about, let's say, ophthalmology or other things, I don't have a specific sense of how in each of the different categories of diseases, to what extent are the classifiers and these things being used. I know that they are being used, but I have no idea how they are being used and to what extent are they effective.
Got it. Thanks. Please move on. Yeah.
Okay. So yeah, so let me come to the the data set. I mean, that will probably make things a little bit more concrete. So the way we started out is that we got access to a data set. I'm not by a reputed hospital from a reputed hospital in Mumbai. I'm not naming the hospital for confidentiality, but yeah. So broadly, this is what they do. So this was like part of a government funded mobile screening program where they collected about 22,000 records from a mobile van, basically about suspected people who would get esophageal cancer. Okay. And then this initial screening, after the initial screening, about 3689 of the patients were basically asked to check with the doctor. Okay, so and then 92 were finally detected with oral cancer. Okay, so this is our data set, and this data set about 169. So we will use the terms fields, features, tests sort of interchangeably. So this many fields were recorded, and again, there was some data sifting done here, and after which we ended up with 49 high quality fields. Okay, we will be also calling them features from the machine learning point of view, or tests, which is from the doctor's point of view. So so here is a description of the features. So so we have about 12 demographic features, 17 lifestyle related features, 15 basic clinical test related features. You can see some of the example features. So these are diabetes, blood pressure, asthma, tuberculosis, cardiac disease, etc. Then 8 medical practitioner features. So these are erythroplakia, erythroleukoplakia, and so on and so forth. So these are recorded by some sort of a medical practitioner. So we don't know for sure whether it was a doctor or maybe a clinician or somebody. Okay. And then there were 4 history related features. So the key idea is that these medical practitioner related features already require some kind of a manual medical help. Of course, the basic clinical tests also require that, but they may be more more accessible. Okay, so this is the idea, and the other features can be collected relatively cheaply. So the demographic, lifestyle, and history related features can be collected relatively cheaply and easily. Okay. So this is the property, and yeah, so this is just sort of yeah, we are showing that the distribution of different features, and sort of we test that so we sort of separate the yeah, so we separate the entire data set into training and test data set, for reporting of results. And so so we just ensure that they follow the same distribution. So this slide is simply showing those. Okay. Any questions? Okay.
No, somebody has a background noise going on. You need to mute yourself. Otherwise, no questions till now. Others, please put your queries on the chat window, or you can hold back till the end for an open Q&A.
Sure. Okay, thanks. So yeah, so this is the overall methodology. So we collect and pre-process the electronic health records into features for machine learning classification problem. Okay. we perform missing data imputation using some sort of a domain rule or average value for, so many of the health, EHR records had different fields missing. Okay. Then our basically strategy is to first find the best classifier for the purpose. Okay. Then ensure that no disease patient gets classified as normal. So, make false normal rate 0. And which is to say that sensitivity should be 100%. Then we remove, clinical test features, which is the medical practitioner features, and also the some of the clinical test features, and then see how the classifiers perform. Okay, and then the last point is that we assign costs to different features and try to find best set of features corresponding to a defined cost budget. Okay, so these are sort of our objectives. This is how
Sourangshu, there's a question on number 2 in the previous slide. Go back.
Right.
How do you do missing data imputation using domain rule or average value? Dr. Vipin, do you want to ask that question, Dr. Vipin?
Yeah, Prof. Good evening, everyone. Professor, thank you. I just want to understand, with regards to missing data imputation, well, there's real world data. And then from our experience so far in iSmart data, we know that 10 to 15% of data is noise. It's noise, or either it's missing. So essentially what we do is we just exclude those records because that is not representative of what we are able to report as a set of clinical parameters, right? So I was just wanting to understand what is the domain rule or an average value, and is it that any missing data, we assume that, for example, I'll give you a simple example. Things like intraocular pressure in the eye. So just as our body has a blood pressure, the eye also has an intraocular pressure.
Yeah.
It can range anywhere between 0 to 90 or 80. So essentially, sometimes you will find that the intraocular pressure is not recorded in a given distribution. We can't assume that it might be normal. So I'm just trying to understand how does this domain rule or average value work in such scenarios? Yeah, thank you.
Okay, thanks very much for the question. So mostly, as you shall see, we do it for the not the test related features, but for the other features. So mostly demographics, lifestyle, these kind of features. This is one part. We do it for, so first of all, we do it for very few records. So actually the reason, so we actually discarded many of the fields simply because of this reason that there was not enough data, or there was a lot of missing data. But we do the imputation for some of the demographic and this. So I agree with your statement that it is not, it's changing the data. What we want to do, so the reason we took this path rather than discarding those records is because we didn't have too many records to begin with. So
you're absolutely, yeah. I'm just sharing our experience, Professor Bhattacharya, that even when we started off to really look at our records, well, I might say that we might have the opportunity to say 25,000, 30,000, 40,000 records discarded. But still, we do have maybe, a large cohort. But essentially, one of the reasons why I continue to report non-availability of information is to tell people that this is the ground reality.
Right.
In the sense, I mean, it's a positive way, right? So it's like an audit for people to sensitize them that if you input good information, you will have an opportunity to, have completeness of as many records as possible. Absolutely. And another thing that I and my colleagues also have come to understand at this point in time is that we report what is there, right? Just because we don't have 10 or 15% of the values you can't ignore the 80-85% and say, oh, I'm not going to report this because it is not complete. So I think that also is a very nice understanding. And if you see all of our papers, we clearly write where the data was available. This was the experience. But again, as I said, I'm happy to understand the domain rules or average value, because this is a issue that will continue to exist because of user variance and input of information.
Right.
You can't control that on the field, right? So because in large networks, you have
So,
a lot of
Dr.
different
Vipin,
HR. Yeah.
I just pasted on the chat window. There seems to be a burgeoning literature in the last few years in medical informatics on how to characterize missing data and how to use that characterization to better integrate missing data into existing data. So maybe
Yes.
I will connect you and Sourangshu offline and you can have a
Perfect.
chat.
Perfect.
What is
Perfect.
the
But nice. Thank you, Professor. But I just thought I'll just
Sure.
Yes. Yes.
try
So
to.
in this context, I will just mention another thing in the context of our work. So I agree with whatever you are saying. Okay. In the context of our work, this was found to be not a bad idea, simply because what we are doing is we are putting some sort of an average value for the missing data, and that would hurt the performance of the method. So if in spite of the missing data, we are able to, let's say, perform within a certain parameter, I'll come to the limits, then we are still okay. That means we didn't need that piece of data or that particular test result for that particular case, because the other results were already sufficient. I mean, I hope that
Absolutely correct, Professor. I mean, again, we'll connect offline. Either it's in the
yeah,
same
I would
column
love. Yeah, thanks.
or
Yeah.
multiple columns. Thank you. Thank you. Please go on. Thank you.
I just want to add a comment here. I'm Dr. Rajan. So the point is, missing data is a part of life, and you have to have a way to work around it. But if it's missing at baseline, that's a different situation. Like if you say, I have included patients of glaucoma, 10,000 patients, but at the first visit itself, the intraocular pressure is not recorded, but the patient has been treated and you have the later follow-ups. It's okay to exclude that kind of patient not in your data. But then most of the time, the problem comes when you have included patients, but the follow-up data is missing. You may have in-between data, or the patient may not have sufficiently followed up. Instead of 1 year or 6 months, the patient came only for 1 month.
Right.
There are ways by which you can impute the data.
Exactly.
One of the common ones we have is last observation being carried forward.
Correct.
But the biggest point is that it should be missing at random. If all the poor outcome patients, their data is missing, and then only the good outcomes are coming to us for follow-up,
yes,
those patients we report that at the end all patients were successfully treated, and those who became blind never came to us for follow-up and we have discarded them. That kind of scenario should not happen. So they should be missing at random, and ultimately you can work around in different ways: best case, worst case scenario, or last observation carried forward. Sorry for the interruption again, but this was an important point that I wanted.
Yes. And I think another very important thing that you are probably pointing out is that if you have a temporal data, then you can do much richer analysis also. So in this case, it was a one-shot data that we had, not over a period of time.
Correct.
So in this case, I mean, my guess is most of the data was missing simply because the person recording the data was, lazy or did not have access to it. One of the two. I mean,
Sourangshu?
Yeah.
Just to let you know, I think it's evening of a Friday. We try to keep our webinars in 60 minutes, but a 10 to 15 minute buffer is generally provided. So just letting you know to control the flow.
Okay. Yeah. So let me just go ahead with maybe the core points that I want to mention here, and then we can also discuss. Yeah. Again, I'm hoping I'm not going into too much detail of the criteria. All of you know. So basically, we look at two main things. Sensitivity. Sensitivity is basically the total number of abnormal reported by total number of abnormal plus the false normals, which is to say that basically it's what fraction of abnormals do we detect. Okay, and accuracy is the overall accuracy. So what fraction of abnormal patients do we detect as abnormal, and normal patients as normal. Okay, so these are the two critical methods that we use. Again, I'm not going to bore you with the details of machine learning algorithms, but I'll be very happy to discuss. I mean, if you have any questions or comments. But essentially, for this, we use some of the most widely used machine learning methods. More so, I would say the kernel methods, which is probably not as widely used. So we will come to it why we did this. Okay. So let us come to our first objective. Our first objective is that we try to find out which is the best classifier. Okay. And here I would just highlight two things. So first of all, when we use the medical practitioner features, we don't have to do anything. The classifier just learns everything fine with very high accuracy and high sensitivity. Okay, so the data is so the detection with all the tests is pretty easy. Okay, so this is the first thing that we know. Okay, but the moment we remove the medical practitioner features, okay, we start failing it. Okay, and now the classifier can fail because of many reasons. So we find two things. Okay, the first thing is that the data is highly skewed. So you remember, out of around 3,000 something, only 92 were positive data. Okay, so what we do is we sort of do a bit of super sampling of the abnormal class. Okay, and we use a technique called SMOT, which does better super sampling by looking at points around the points which are being super sampled, rather than just copying the points blindly that many times. Okay, so this is one of the things that we do. Okay, and then we start our classification process. Okay, so here are the results. Okay, and so for the unskewed data, let me just look at it. So yeah, so you can see that the top table reports the sensitivity and accuracy for the skewed data, and sensitivity is very bad. It's in the range of 9% to 12%. Accuracy is always good, so which tells us that accuracy is not a good measure, again because of the skew. Okay, but now when we unskew the data using SMOT, we don't get good. So towards the left, I don't know if you can see my pointer, but towards the left here is
yes, we can.
Okay, yeah, so towards the left are the naive implementations of this algorithm. So naive Bayes random forest, and SMO is for SVM. Okay, support vector machines. Okay, now these numbers again are not looking very good. Okay, so what we realize is that there may be a nonlinear relationship between the features. So I actually did not describe some of the feature transformation. So we do usual, for the features which are by categorical, we do a binary transformation, and we keep the numerical features like let's say age or something like that, those kind of features as it is. Okay, and we sort of suspect that there is a nonlinear relation. And so we use kernel support vector machines of degree 2 and degree 3, and also kernel logistic regression, which not many people use. But so this was one of the novelties of our work, that we also tried this. And then here we see that we achieve 100% sensitivity, and yeah, so pretty good accuracy as well. Okay. But for us, sensitivity is very important. Okay, so this gives us hope that things can be done well. And then yeah. So
there's a quick question on the chat window. Please explain the medical practitioner feature.
Okay, let me just go back. Actually, I'm sorry, I'm going fast. Oh, okay, I don't know what is happening. Yeah. So medical practitioner features are features like erythroplakia, erythroleukoplakia, mucus fibrosis, ulcer, etc. I don't understand any of these, but these were the features.
No, these are the pathological features of the tissue that medical practitioner expertise is required to characterize.
Right. That's my sense also. Yeah. And these basic clinical tests are probably the features which can be calculated, or which can be somebody who is not maybe just a basic clinician, they can calculate. They don't need a very experience or very qualified medical practitioner to do it. Okay. So yeah, so again, this is AUC curve, and we see quite good AUC. And
you have to explain what is the AUC curve for the audience.
Okay. So so basically, what we are saying here is that so on x-axis is the false positive rate. So basically, how many abnormal guys, sorry, so how many normal guys are we, marking as suspect? And on the y-axis is the sensitivity. So how many suspects are we detecting? And as we vary the threshold, so I'll come to the threshold in a minute. As we vary the thresholds of some of these classifiers, so especially the support vector machine and the logistic regression based classifiers, okay, we can achieve various false positive rates depending on where we choose to draw the boundary between the positive class and the negative class. Okay, and by varying that, theoretically we can achieve this curve. Okay, so that's what it is. So it's basically showing you a trade-off between sensitivity and false positive rate. So this is a good curve, because what we are showing is we are achieving almost 100% sensitivity with something like 33, 33 or 30% or something like that false positive rate. So we are only calling about 30% of the normal guys as positive. Okay, yeah. So this is what it means. Now this curve. So this is a good curve. The shape of the curve also depends on how many features we use. So left here is the one where we use the 49 features. Okay, and right here is the one where we use the 63 features. So so basically here you can see that it's almost bang up. So even without classifying anybody or very few false positives, we can already get 100% sensitivity. So this is a much better this thing. And this is captured by this number, which is the area under the curve. So you can see on the right, the area under the curve is, so highest can be 1. And so this one is, very close to 1. Whereas towards the right, it's slightly less, but still it's a very good curve. Towards the left, it's slightly less, but it's still a very good curve. So I hope this is easy to, I hope I was able to interpret the curve for you. Okay, so let us go ahead. We also did some feature analysis. Again, we found, so another thing which is sort of somewhat special in our work is that we use kernels of up to degree 3, which means that we can sort of capture feature correlations of up to 3 features at a time. Okay. And sort of we tried to figure out that which features, we generate a lot of combinations. I mean, you can understand that we had about 69 or 63 features, and all 3 combinations would be along, I mean, all up to 3 combinations. So of all 1 combination, 2 combination, and 3 combinations is what we consider. And then we do a linear model in the higher dimensional space, and then we basically find out the most important 20 features which we can find out from the model parameters. And these are those. I'm sorry. Yeah. So this is a list of those. And yeah. So so one thing we noted here is that these are just marked as more important, but there are many features which are highly correlated with the 12 most important features found here. Yeah, and basically we sort of identified the 12 most features which in combination with each other. So occupation, smoker living in same house. Okay. Yeah, you can see that tea consumption, okay, marital status, all these sort of features came out to be important. Okay. Okay. I'm going to skip this. This is also the feature correlation analysis. Yeah, if you are, yeah. So let us come to the second most important objective of our exercise, which is to find the optimal threshold. And remember, we were discussing about this making false negative rate 0, and can we do that? Okay. So in order to do that, what we did is we had to further split the training set into a validation set and a train set. Okay. And what we would do, so this is the split. So the entire 100% data was split into first 70% training set, 10% validation set, and 20% test set, which we will finally perform our experiments on. Now, what we do is we compute the sensitivity on the validation set of a classifier trained by 20% of the training set data. Okay. And then we find out the threshold. So we can find out the probability threshold for which we get false normal as 0 or sensitivity as 100%. So this could blow up the false positive rate, which means this could reduce the accuracy drastically. Okay, but we don't care. We want to get all the false normals out. So we don't want anybody to escape the sieve, so as to say. Okay. And then we are reporting now the results on the test set. So this is the, I'm skipping the flow chart and the algorithm. If I'm hoping it is clear. Okay. Yeah, so first we tried without basic clinical test features, and we could not get very high sensitivity. So we started adding the basic clinical test features then. Okay. And then yeah, so then after adding all the basic clinical test features, we see that kernel SVM and kernel logistic regression, they achieve 100% sensitivity. But so here it doesn't, because here we are using the threshold, the default threshold. So I'll come to here. Okay, so this is kind of the one of the key results, that we remove each of the features, okay, and then we calculate the threshold, and this is with kernel logistic regression. And here the kernel logistic regression has a sort of advantage over kernel SVM, even though kernel SVM is also equally, if not more accurate. Kernel logistic regression actually gives a probability as output, a class probability, and we can very easily tune the threshold on a probability because it's bounded between 0 and 1. And we can also easily interpret that probability of threshold, okay? And these are pretty high threshold. As you can see, we are achieving, so we are taking very high threshold, okay, in order to achieve like false normal. So in some cases, we were actually not able to achieve false normal. So this is the, so this is the initial false normal, and this is the false normal after increasing the threshold, okay? So, but for, so till about 57 features or so, we were able to achieve the false normal, okay? And we also report, so this is basically the post sensitivity. You can see that we achieve 100% sensitivity, okay? Starting from about 90% sensitivity here. And we are not compromising too much on accuracy. So we are getting accuracy of 98%. Initially, we had 99%, but we are not compromising too much on accuracy. So this is kind of our one of our most hopeful results, okay, that we can actually, so first of all, by using just basic clinical features, we can achieve a false normal rate of 0, okay, and also we are not compromising too much on the accuracy, at least for up to some 57 features, okay. Yeah, so this was our second thing, and basically we show the same thing in graphs here, and you can see as we remove the features, basically the post accuracy drops, okay, and it drops more than the initial accuracy. So the the normal threshold that we select, which is basically 0.5 in case of logistic regression, because there's a 50% chance on each side, okay, that maximizes the accuracy, but doesn't sort of doesn't prioritize the false normal rate or the sensitivity, okay. So this was our second, and our third work here was can we assign some kind of a cost or discomfort factor for the for each of the tests, okay. So yeah, so we so our steps were something like this, that we assign cost or discomfort value to each of the tests, okay, and then we set a budget on total cost or discomfort value, okay, as a patient constraint, okay, and then what we do is we enumerate all possible options which satisfy the constraint, okay. So there is so based on the cost and the budget, certain tests may be certain combinations of tests may not be feasible. So you enumerate all the combinations of tests which are feasible, okay, and then we use, so once we have these, so then we say that these particular tests have been conducted, so these features are now available for us. So can we can we achieve this false normal rate of 0 under this constraint, and then yeah, so this is our basically steps, and this is like the sort of the cost and the discomfort factor that we assign. This is just some sort of a placeholder, I mean, but the methodology is important, okay. And then we do this budget enumeration where we basically find so here we are sort of talking about the different combinations which are possible within the budget. Okay, and so we have set a budget of 2,000, and then we are just checking which tests can be performed, and those features will be available. And then corresponding to these budget enumerations, now we are so we are talking about this false abnormal rates. Okay, for these budgetary for these guys. Okay, and what you can see here is okay, so these are the cases, but yeah, so option 8 here produces the minimum number of false abnormals. So this is 9 false abnormals with 100% sensitivity. Okay, so so the percentage number here is the sensitivity number. Okay, and the bar indicates the size of the false abnormals that we require. So then we can suggest this particular test combination, as you can see. Yeah, so this is like in this case, this is corresponding to RBS LB glycometer followed by yeah, reflux gastritis. Yeah, so I don't understand all the features, but yeah, so this is what the sort of the math suggests basically. Okay, so again, our understanding based on this particular data set is that it is possible to incorporate these kind of cost or comfort considerations and still come up with a strategy where you can have a false normal rate of 0 or 100% sensitivity, and not too high false abnormal rate. Yeah, and this is with the same thing with some sort of a comfort factor that we perform, but it's essentially the same idea. Yeah, so that kind of brings me to the conclusion. Yeah, so basically, I just want to say here about the implication that we are trying to design. We were trying to design a method of screening and screening where patients who achieve, let's say, who suppose we are achieving a false normal rate of 0. And then we are suggesting, people that you don't need to go to a doctor. Okay, so you don't need to go to a hospital. Okay, based on some lifestyle, tests. Okay, so some demographic and lifestyle, and maybe some basic clinical tests. Okay, so based on that, we are suggesting to these guys that you don't need to go to a doctor. Okay. We may suggest, because we are trying to achieve a false normal rate of 0, we may have a lot more false positive also, depending on the particular case. But the methodology tries to minimize that fraction, so that it minimizes basically the load on the medical system. And this basically so we discussed in the paper that this helps everyone basically. So this helps the patient because his or her time is not wasted. This helps the doctors because they are not swamped. Okay, and most importantly, like not most importantly maybe, but at a more high level, maybe let's say the society, let's say some medical insurance company or whoever it is, they can utilize such a system to do a pre-screening and yeah, so reduce the load on the doctors, because the doctors are kind of the precious commodity. And yeah, with that I'm done. Thank you. So
Sourangshu, there are some questions on the chat window on training and test data set? Do you want to take them?
Yeah. So
How do you decide how much is a good N for training and test data set? Basically, that's the question.
Okay, so what is the ideal split between the training and the test data set? So yeah, so what we did is we had the 20% test data. So basically, yeah, so we had a 20% test data. We had it because basically we are assured that I mean, so yeah, so there is low variance in test error. So we have to assure low variance in test error. Okay, I see Ashish is here. I didn't know Ashish is here. So hi Ashish. So please feel free to, so this is his work. So please feel free to sort of join in if you have any comments, Ashish.
Yeah, thank you very much. Thank you very much, sir, for giving me an opportunity to talk. Yeah, actually, this was a 10-fold cross validation. Other than split 2:1 we have initially done, but then 10-fold cross validation we have also done. And the result, yeah. So.
Yeah. No, I think he's talking about the selection. There it was only train test split. The last experiments.
Okay. Other questions?
No, I mean, Professor Sourangshu, thank you so much. Very informative and very excited to continue the conversation even post the webinar. So my thing with train test is even we did the kind of patient forecasting model, expected number of patients who might actually footfall on a particular day to the hospital. There also, of course, I mean, train test, I even for me, I wanted to understand, is there kind of like a power of a study which determines the sample size? Is there something which determines the ratio? Because there also in a temporal data set, you had to maybe compare the first 3 years and then apply it for the next 7 years. Or as you mentioned, you had a 20% for your training and then you're using the 80%.
Okay, so there, from purely machine learning point of view, you select the test set size so that the variance in, the metrics, let's say you are calculating accuracy as a metric or sensitivity as a metric. So the variance in test metrics should be low, should be within. So for example, we have to, so in our case, for example, so we had a total of about 100 positive cases and the number of negative cases were very large. So 3,000, so it doesn't matter. So if we take 20% as a test set size, we have 20 positive cases in the test set. Okay, and like a few hundreds negative cases. Okay, so we kind of are ensured that the variance in the test accuracy or test sensitivity is low. So that according to me should be the criterion for selection of the test set size. And whatever is left, you split it into training and validation. Yeah.
Perfect. Thank you, Professor.
Rahul Negi has a question. What needs to be the sensitivity and specificity of test data?
What needs to be? Yeah, so that's what, so we were trying to achieve 100% sensitivity. And yeah, so specificity is something we did not measure. Instead, we went for the accuracy, which is, I guess, I mean, once you have the sensitivity fixed, you are basically bothered about, yeah, so we were only focusing on the sensitivity. So we should be able to detect all disease students, all diseased patients, sorry.
Yeah, Prof, but also that at large scale screening, of course, I think it's an evolving question. Do you want to confidently say you don't have the disease versus you have the disease? And then do you want to err on that you might have the disease, right? So the point is, even if it's a false positive, referring a patient, like when we speak of these algorithms or checks where people are able to screen and then maybe refer to a higher center,
right?
Still want to err on saying, okay, even if I send 80 patients for referrals, if at least 20, 30 of them get picked up as true positives with further examination.
Right.
Right? Because if you're looking at technology being utilized at scale to enable even regular, healthcare workers to pick up, cases or people who are at risk. So anyways, I think that is something we can always, discuss offline, but thank you.
Sure. Yeah. Thanks. Yeah. We can definitely discuss that. Yeah. I mean, so I must say that this is just one work. I mean, this is just on one data set. I'm not at all sure that this can be achieved everywhere. But we can try. I mean, we have, like, at least for this one, we have HOPE. This particular data set, we have HOPE. And we have a methodology, so we can try. I mean, I think that's the best.
I had a quick, I would say, a philosophical question, which is, and this can be the last question. Why is it that now there is an advent of using machine learning classifiers to help in healthcare screening and reduce the burden on the healthcare systems? You started with the NHS numbers. I mean, data on screening existed 20 years back as well, maybe not in a digital format, but people were writing it down. And these classifiers also, I think the algorithms existed in the computer science. So what's happening now, do you think, as a computer scientist, that makes it people come in much more into this medicine space with artificial intelligence?
Yeah. So at the very outset, I must say I have very limited understanding, but with my limited understanding, I will try to say 2-3 things. So first thing, as I understand, so actually, even before I was working in the field of bioinformatics, not exactly medicine, but the general story either in medicine or in bioinformatics was this: data was not freely available. I mean, data was there, but not freely available. Data was expensive to procure. So that was the first, at least for somebody doing research in India, that was the first big hurdle. Okay, I think that hurdle has become more relaxed in the past decade, at least in the Indian setting. I'm just saying. Okay, so this is number one. Number two is, I would say, data quality. Okay, so for example, we were able to, so a large part of the work that Ashish actually did is to manually screen, look at each and every feature and screen out, these are the features we don't need. I mean, it's not easy to look at just the data and say that there is a lot of noise in this particular feature and we need to discard. So that the data cleaning is another sort of, I would say data cleaning is, of course, work that needs to be done, but after cleaning, availability of enough clean data is the second part that sort of we were very lucky to have with this particular data set. That's the second part. And I think that has also been, I mean, again, this work is, I mean, it was published 2 years back. The work itself is about, I would say, 4 years old. That was, I mean, I think now there is a lot more data available and a lot of people are, working towards this. Another thing is, I don't know, there is also some government initiative. I think it started, I mean, this particular data was actually, I think that the hospital, they collected this data and they made this data available because, it was part of a government funded program. So yeah, I would think that, I don't know how much the government initiatives are helping now, but definitely government initiatives will also help in this matter, I think.
Okay. Thank you very much. Dr. Vipin has added one of his articles recently in Indian Journal of Ophthalmology. So everyone may want to take a look on how you use big data in the medicine context. I think there are no more questions. So Sourangshu, much appreciated. Ashish, thank you for your time. We will remain in touch, of course, on research questions, and wish everyone a very nice evening and weekend.
Thank you, everyone.
Thank you.
Sourangshu, thank you.
Thank you so much.
Good night.
Thank you.
Thank you.
Yeah, it was very nice actually discussing with doctors who are specialists in the area. So I'm actually more on the machine learning side. So I would be, I mean, I'll get in touch with Dr. Vipin and
You should do a trip of LV Prasad sometime, give a talk,
yes,
and also talk to them about their electronic record and what are their questions.
Prof,
And
where is Professor Sourangshu based, if I may ask? Sorry.
Kharagpur.
Oh, Kharagpur.
Yeah.
yes, yes,
Okay, great. Professor Sourangshu, I'll connect, as Professor said, I have your email ID, but we'll just connect offline and then just share some thoughts. I have some thoughts to
I
definitely.
will be absolutely, yeah. I mean, I'll be really interested to do that. Yeah, yeah. Because, yeah, so in this particular work, we got the data, but we didn't really interact too much with the doctors. So I have always wanted to interact with, the doctors and the people
No,
who
I
are.
strongly believe that it is a mixture of both the domains. And that is where the magic lies. That is where the most relevant questions get answered. And also the relevance of the use of machine learning, the broader medical community will get to understand. So again,
Yes.
as I said, I look forward to catching up and speak soon. Thank you so much for your talk this evening.
Thank you. Thank you very much.
Thank you, Prof. Thank you. Bye-bye.
Thank you. Bye.